Hi, everybody, and thanks for joining us for today's webinar on resilience and business continuity. My name is Amy Herrera. I'm a special agent and private sector coordinator at the FBI's Washington, D.C. field office. And before we get started with today's content, I have just a few administrative items to go over with all of you. First off, we are recording the session today. You'll be able to access it in two spots. One of them is on the InfraGard portal if you're an InfraGard member. Special welcome to InfraGard members today. If you're not a member, you don't know what that is. It's the FBI's primary outreach program for owners and operators of critical infrastructure. So free to join, more details available at the website, which we'll throw up in a moment in the chat box. The other place this recording will live for people who are not members of InfraGard is on a public-facing website that is hosted by our friends at Health and Human Services. So we'll also throw that URL in the box so you know where to reference that. If you're attending today to get continuing education credits, you will receive an email tomorrow with a certificate that confirms your attendance today. So you're welcome to use that and submit it to whichever organization typically issues your CEUs. Feel free to do that as soon as you get your certificate link tomorrow. If you're a member of the media and you are looking to write a story about what we're talking about today, please reach out directly to us through the chat box or the question box, and we'll connect you with the right public affairs folks who can help make that happen. As we're going along today, we welcome your questions. Most of the questions we're going to wait to handle until the end of the presentation today, but as the questions occur to you, please do type them into that question box, and we'll get to them as we go if we can, and if not, we'll handle them towards the end of today. If you've not already seen it in the handout section, which is under your options dropdown, there are two handouts there for you. They are the two sets of slides that our two experts will be using today. So you're welcome to print those, download them, follow along, and that way you won't have to take so many notes. I am here today representing not just the FBI, but also the National Capital Region chapter of InfraGard, which is for InfraGard members who live and work in and around the District of Columbia and Northern Virginia. But another key partner of ours who's going to give you some words of welcome is Dr. Laura Wolf, who hails from the U.S. Department of Health and Human Services. So Laura, I toss it over to you.
Thanks very much, Amy, and good morning or afternoon to everyone on today's webinar. Thanks again to my partners at FBI and National Capital Region InfraGard and our partners at CISA. We have a great web series for you today, and I have a couple of notes for the web series moving forward and some historical documentation. So first of all, next week we will be taking a break in the action. A lot of people are getting some summer vacation in, so we will respect that and have a break in our webinar series next week. The week after that, we will be back talking about physical and logical access management. So if you are taking a break and a vacation, please remember to be safe. Please wear a mask, keep your distance where possible, and wash your hands. So today is our 10th installment of the Securing the Health Sector webinar series. We've put the URL in the chat box where you can find information about the previous 9 webinars. We are slow to get the recordings up. You should see a bolus of them posted next week. The transcription takes us a while, so apologies for not having those posted immediately, but we are not a team of typists. So we are dealing as best we can. So today for the 10th installment, we have a great set of experts with us today, and we're going to cover facility infrastructure, resilience preparation, COOP planning, recovery of critical business functions and processes, and thinking about business continuity generally. This is important in the current pandemic. It's important as we are in the middle of hurricane season and looking toward our first tropical storm Phe, affecting the mid-Atlantic and Northeast over the next several days. I will say it's never too late to have a plan. Even when you're in the middle of a long incident, planning for the future is important. So glad to have our two panelists today. I'll introduce them and then quickly turn the webinar over to them. We have Kyle Wolf, who is a familiar voice for us on this web series. He's the DHS Protective Security Advisor for the National Capital Region and has briefed us before on threats to the health sector. As a PSA, he facilitates and coordinates vulnerability assessments for local critical infrastructure and assets, and is a great resource to our private sector partners in the area. A reminder that PSAs are located in all regions of the country, so you should know yours. But Kyle is back with us again today to talk about resilience. He's joined by Christopher Son from HSS, a leader in healthcare security services, systems, and training. Christopher is the Senior Director of Emergency Management and Enterprise Resilience for HSS. He comes to us with over 15 years of industry experience, leads teams of emergency management experts, and they also provide delivery of training and exercises and consulting engagements. So we're so glad to have them with us today, and I'll turn it over to Kyle to get started.
All right, good morning or afternoon, depending on where you're dialing in from. And welcome to my very quick resilience considerations presentation. I'm Kyle Wolf from Department of Homeland Security, and who I represent in Department of Homeland Security is the Cybersecurity and Infrastructure Security Agency, or otherwise known as CISA. In CISA, it's all about protecting our nation's critical infrastructure. So my position within CISA, as Laura just said, is a Protective Security Advisor, or a PSA for short. And as a PSA, it's my job to inform critical infrastructure, like hospitals or any type of healthcare really, on security and resilience. And once again, as Laura said, there's PSAs all across the United States, and you can see on this slide right here that we're divided up into regions. And if you are, all you got to do is basically find your region and look down into the emails right there, reach out, and they will connect you with your closest protective security advisor. So this presentation is just the tip of the iceberg into your resilience possibilities. If you're an emergency management specialist, I don't think I'm going to reveal any earth-shattering advice. But as I have learned through my time as a PSA, each nugget of information that we garner from each other makes us and our facility stronger. So once again, reach out to your PSA for facility-specific and a free, yes, I said free, in-depth review of your security and resilience. This information is gathered that's gathered in this presentation is built from statistical analysis from Department of Homeland Security and Argonne National Laboratories, gathered nationwide, along with my personal experience as a protective security advisor. And in resilience, we know we need to start with planning. Without plans, we're just winging it, and we all know that that is less than efficient. So whenever I visit a facility, these plans that you see on the slide right here, they top the list in what I'm looking for. They don't have to be named exactly what I have right here, but ultimately I'm looking for those references that kind of cover these areas. But today we're talking about resilience. So the plan that we're looking for that's going to most cover this in resilience is our business continuity plan. Now, I'm not going to dig down deep into the business continuity plan. Actually, Chris, the next presentation, he definitely is going to dig deeper than I am into the business continuity plan. But I did want to throw up a resource right there. FEMA has www.Ready.gov, and it has an entire suite that's built so that you can understand what a business continuity plan is, what it does, and how you can actually build one. They have a template and gives you a really good start. They also have some YouTube videos that really explain these. This really good. So I would suggest you get that, take it down, and go with it. Oh, also, yeah, if you download the handouts, all of this is in the handout, and then even some of the references that I make as I go on that you don't see on the slides will be in the handout. So what we're talking about for my portion of the PowerPoint here is specific considerations for infrastructure dependencies. So it's not a comprehensive list, which is not achievable in the 15-minute period of time that I'm going to speak, but I will highlight some of the top issues that I see and my colleagues see. Get an understanding, I throw this slide up here to show hospital dependencies, and I think we all know dependencies like power, water, and so on. Well, with 100 hospitals that have been surveyed by PSA, it displays through statistical data in the slide that how long it takes to seriously degrade a hospital if services are lost. As we can see, power jumps out. Obviously, that's immediately important, and I don't think I need to harp on these dependencies. They're not going to be a surprise to anyone. But what might be a surprise is if they don't have redundancies, if they're not built into your facility, massive degradation can start within as little as 5 minutes to a couple hours. So given that this is the case, we would assume all hospitals have backup plans and systems built in, wouldn't we? Well, this slide shows, kind of goes a little bit more in depth on, well, what we see as protective security advisors. This graph depicts a sampling of hospitals. It's over 400 surveyed across the United States. It shows that obviously these dependencies are recognized, but not all hospitals have the same amount of effort into that resiliency. As you can see in the second through fourth columns here, there's a varying degree of resiliency built in. So what I'm going to do in the next few slides is just give you some ideas to help beef up those areas. As you can see here, I have the same list of dependencies or of utilities. When I visit a facility and discuss utilities, one of the first questions I'm going to ask you is, do you have multiple connections? To explain that a little bit better, I'll use power as an example. Do you have one power feed that supplies your hospital, or do you have more? If you have more, can each feed supply 100% of power needed? So what I'm doing right here is I'm gauging the importance of that or those feeds. And you can do this with any and all utilities that you see up there. Next, I'm going to ask where those feeds come into your building. Do they come into the same geographic location, or are they separated? What I'm looking for here is if they enter the facility at the same place, then what we've created is what we call a single point of failure. To put it in layman's terms, in other words, if I have a fire in that room, and let's say I have two power feeds, but they're both coming into the facility at the same room, I have a fire in that room, what just happened? Well, it doesn't matter that I had two feeds because they both came into the same room and that fire destroyed all the equipment associated with supplying power to the hospital. So that's what we're looking for as we, kind of delve down into each of utilities. So I'm looking for, is there one connection or multiple service connections? Do they terminate in that same room like I just talked about? And then I gauge the importance of that room and maybe even give an increased significance if, those things occur, those, possible things that might go wrong. Also, something else we look at is in that, and a lot of time we call it the mechanical room. In the mechanical room, what else comes into that very same mechanical room? Because I just gave you an example of power and power. But what if another one that I often see is power and your communications come into that same mechanical room, and then there's a fire? Well, you not only lost your power, but you lost your communications, right? If your communications can't get in and out, your power can't get in and out, you've just doubly hurt yourself, if you will. So those are things that really kind of bump up the importance of those mechanical rooms to keep your obviously hospital just up and running, because that's the most important thing, right? So what we can do is, if we decide that, okay, we obviously know these utilities are important, and some of them or some of these rooms might be even more important than others, we might need to bump up our security and make sure that our security professionals understand the importance of those rooms and why they're important. So just by bumping up our security, we can have roving patrols. Obviously, we want these always behind locked doors. We could even dedicate a camera that points to those rooms or even in those rooms, so that maybe even if that fire starts, we can have somebody instantly get on it and avert a catastrophe. So all security considerations that kind of go hand in hand with those utilities and the importance of keeping that facility up and running. And then if you walk on around the outside of your facility, you can see the picture I have depicted here. There's gas lines, and I see this actually more often than you would think. But there's nothing that protects those gas lines whatsoever, even from an accident. Now, if your gas lines are right next to a parking area or maybe even a delivery area where people are driving, I would suggest the same thing. You at least put up bollards, something to protect your utilities. Otherwise, it's going to end up in kind of could end up in a bad situation. And lastly, I'm going to say, make sure you talk to your provider. Get with your provider of all of the above, power, water, gas, all of them, and have a direct point of contact, and put those points of contact in your plans, because you should be priority. So make sure your provider understands that you are priority and why you are priority, so that they make sure that they get that utility up and running to you before everyone else. And I would even go so far as to have a liaison with your utilities and create that relationship, because you want a direct dial number that you can call and get your facility back up and running as fast as possible. So some other items to consider. On the table a few slides back, we saw that 99% of hospitals have backup power. So what does that mean? Often that means generators, like the pictures you see right here. Now, when it comes to generators, I'm going to have you ask yourself some questions about your generators. A lot of times people have generators, but they don't understand the full capabilities of them. So one, ask, how long will my generator last with the amount of fuel that I have on hand? That's very important, because fuel is, doesn't always just, show up, or if you've seen past disasters where there's lines and lines of fuel. So my next question is, do you have a contract or procedure to refuel your generators? And you need to have that in a good time frame. So you need to know how much, or how long those generators are going to last. Then, what level of operations will my generator support? Is it going to be 100%? Make sure you know that. Make sure that you do full load tests that stretch that out and show that, yes, my generators do 100%, or you understand what they do and what they do not do, so that you can incorporate that into your plans. And lastly, once again, make sure they're physically protected, like the picture I have right there. They have, at the very least, bollards, so that somebody can't come in accidentally, run right into your generators. Obviously, that'd be a bad day, right? And then we got water. Conduct a water audit to understand the facility's water usage, then evaluate alternate water supply options. Now, I'm not going to get in depth here, but where I would recommend that you go is cdc.gov. They have a emergency water supply planning guide that was built in 2019. It's up to date, really good planning guide. It really gives you the down and dirty of things you need to think about and alternate procedures that you can go to supply water for your facility. So really good. And then once again, with your water, your wastewater, to reach out to those providers and see what contingency they have in plans they have in place that could help you out. Because a lot of those guys will help you out, any way they can, and they have these plans already in place. But obviously, they would need to coordinate them with you. And then my last slide is a couple. Oh, by the way, some things that people don't often think about. Air intakes. I'm going to venture to say that you need your heating or cooling, depending on what time of year. You really need it bad to keep your facility up and running. So where are your air intakes at? Do they have protective measures around? We personally like if your air intakes are like up on the roof, 30 feet, where people can't, really mess with them at all. But if they're not, if they're down on ground level, have some protective measures such as screens to protect any kind of malicious acts. Just like those utility rooms, deploy those security professionals in regular patrols and inspect those outside air intakes. Make sure they understand why they're important for your facility. And you can even dedicate a camera to those and watch it at all times. Also, going one step further, I would see what the operations of your air system, and can it be immediately shut down? Do you have procedures for that? Who knows how to do that? Or can you also manage the flow of that air? Can you reverse the flow? If somebody was to put some smoke or gas or whatever bad, can you turn that flow around and kick it out of your facility? Things to think about. Moving on to critical products. I don't think I need to harp on this one because COVID, obviously, everybody really got a check on your supply chain, right? Everybody had to figured out what do we need to do to make sure that our supplies keep running. Just make sure you prioritize, you talk to your suppliers and map out the supply chain all the way to the end so that you have a good understanding. Is that supply available from other vendors? And determine your supply requirements, because you might want to keep extra on hand if you think there's going to be a critical concern. And then the last one I'll talk about is transportation. A transportation route. Usually this doesn't apply to hospitals. Usually it's when I talk to people about a transportation route is you have one way in, one way out. And that could even be a choke point because of a bridge or something like that. Well, kind of new because of the COVID, new routes that limit the spread of it have been created, those that do require you to go one way in and one way out. So if you look at that picture right there, if that was to happen to your little traffic pattern, is that going to affect your facility? That's, I would just say consider this and how it affects the facility, and plan around it, plan accordingly. Make sure that you have those contingency plans that could, route those people around and still trying to achieve the effect that you want. Give you one quick resource from CISA. This is kind of the one-stop shop for DHS CISA, and you go to this website right here that I have on the bottom, Securing Soft Targets in Crowded Places. Now, when you get to that website, you look for the resource guide. You click on that, and then you can download the resource guide, and everything in there is available, and it's free, and it's all the services we and DHS CISA provide. So I tried to keep it down dirty and quick as possible. I was Kyle Wolf with the Department of Homeland Security, and I appreciate you all listening. I will stick around for questions whenever we have questions. Now I will turn it over to Chris Sonny, who will keep this presentation going.
Yeah, absolutely. Thanks so much, Kyle. And I also want to say great insight on that as we switch over here to my PowerPoint presentation. Really appreciate the information that you share and all the work that CISA does. As Kyle mentioned, my name is Chris Sonny. I'm the Senior Director of Emergency Management and Enterprise Resiliency at HSS, lucky to lead our business continuity team across our enterprise. And what we're going to be chatting about today is really focusing a little bit more on the operational standpoint of business continuity planning. As I said, Kyle did a great job talking about a lot of the other key fundamental aspects that we need to have for our plans to be successful, and great considerations. We're going to turn a little bit and take a look at what is that business continuity plan within healthcare. How do we start to integrate this plan with our emergency operation plan, a disaster recovery plan, and then a BC plan? Where do we all fit in, and how do we play well in the sandbox with one another? And key, we're going to talk about gathering some really important information for our plan, how it can't be done in a silo. We really need to leverage the subject matters within our organization. We're going to talk about some key points when you're looking at those different critical functions that we need to broach to ensure that we have a plan that's truly reflective and effective for the organization. Now, as we've seen throughout our response, and at some points even recovery to COVID, we're truly going through an event that rare, if any of us, have a comprehensive plan to address. The impacts, the number of impact points, and how our workforce, our supply chains, our overall operations and revenues have been impacted is truly unprecedented. But we do see a couple key areas of opportunity when we look at our business continuity processes and plans across the spectrum in healthcare organizations within the United States. First of which, this long-term incident action planning, where we're going through multiple operational periods, days, weeks, months on end, with varying degrees of impact, varying degrees of members of the incident management team, is kind of a newer concept to many of us within the healthcare community specifically. And there's a lot of areas of opportunity for us to ensure that we can continue with developing proactive business continuity plans and incident action plans, rather than just simply falling into that reactive rut and simply reacting to the information that's coming at you. I like to equate it to having a good incident action planning process. Following that planning P is kind of being that difference from kind of drinking a cool cup of water out of your mug from kind of then drinking from that fire hose. We really want to try to really align that information we're receiving to make it digestible to not only our incident management teams within the organization, but all the way down to our frontline staff as well. We also, as we start to take a look forward into our recovery and also our current and ongoing response operations, taking a look at those next steps, identifying what we need to do for that closed point of dispensing or pod plan for if and when we get to that point in which a vaccine is available, and expediting those resources to our staff. We also take a look at the ability to flux for critical care and intensive care areas within our organization to meet the demands of rises or falls of COVID within our respective community, ensuring we have the correct staff, resources, and facilities to care from them, and also starting to look at what are those minimum essential staff that are needed for those critical functions. And not meaning that we're looking at lists of how and who we're going to furlough, but how can we then take those resources and realign them to support kind of those key priorities, tactics, and strategies of our organization, and to sustain those essential functions. And then we've also taken a look at those plans for prolonged teleworking I'm sure many of us who are now working from home, if we have the ability and luxury to do so, thought, hey, this was going to be fun for a few weeks, but now as we're a few months into this, it's kind of a different reality. And what are some of those different needs that we have to help support our workforce? And then again, as Laura mentioned, great segue into not only with our COVID-19 response, but also as we take a look at being in the midst of hurricane season, how can we effectively evaluate our supply chain considerations? Outside of maybe the shortages and areas of opportunity and some of our personal protective equipment, take a look at our past hurricane seasons where we've seen impacts to our saline solutions, saline bags, medications, certain medical equipment based on the impact of hurricanes or storms, or even as we may see flare-ups of COVID in different regions and parts of our country and also around the world, how is this going to be a consideration to our supply chain? So a lot of these items that we take a look at, especially that discusses the impact of COVID, really is kind of in the basis of all hazards planning. And a lot of these different items can actually be covered within a good comprehensive business continuity plan. And we're going to talk about what does that mean for us in healthcare and kind of what are those fundamental steps for us to go ahead and build that for our organizations as well. When we talk about business continuity planning, what is continuity planning in itself? Different names, right? Many of us in healthcare refer to it as a BCP or the business continuity plan. A lot of folks will also refer to it as a continuity of operations plan or a COOP. Effectively, I'm not worried how we get to Walmart as long as we all get there together. What we're talking about is continuity and resiliency planning for our organizations. And kind of the three pillars that we look to build these different steps on are really looking at the people, the process, and also taking a look at the place. So we take a look at the people. We're not just looking about the staff that we need on a daily basis, but what are those long-term effects from a prolonged surge as a result of this incident? If we're now expanding some of those critical care or intensive care areas within our organization, having the appropriate nursing staff, respiratory therapy, physicians, and all the other supporting players that we have to provide that effective environment of care, what is their ability to have that surge and then prolong that surge as we have these different waves and sustained waves that are impacting our respective areas? And then what would that look like if we then start to see an uptick in absenteeism? If we start to get above that average, give or take 10% absenteeism that we normally see, and as we start to have an increase of such, as a result of staff either being sick themselves, taking care of family members, or are the primary care providers or caregivers or overseers of children that then need to address some of these other external considerations as well. We're going to talk about human resources consideration a little bit more in detail, but one of those key aspects we need to start looking at on the front end before we find ourselves again on the back end of this response. We also take a look at some of that succession planning for leadership and departmental leadership within our organization. Who has the ability to make certain decisions within our organization? Ensure that ability isn't siloed to a few key positions, and we do have a succinct plan to identify who else would then have the ability to make key decisions for our organization in absence of those individuals, so we can have a sustained response and minimize any interruption to normal operations or response operations as a result of this event. We then take a gander at the process, right? We take a look at who are those key departments and the critical functions within the organization. And I'm not talking about getting back to the Office movie with the Bobs, where they come in as consultants and say, who's important, who's not, this is who we're gonna cut, this is not we're gonna cut. But as we take a look at a whole of organization response, we see where can we reallocate those resources. If we have nurses such as my wife, who used to work in ICU and is now working in one of the outpatient clinics, where she says all good intensive care nurses go out to pasture at the latter part of their careers, what is the process for us to repatriate those staff? How can we ensure that if we identify an outpatient service as maybe non-essential at this time, or we have the ability to delay or reschedule those services until a later date, well, then what are we going to do with those available resources? Do we have the ability to bring them back in within the organization to support those key operations that we're identifying? The other piece that we really want to focus on within our continuity planning in healthcare is not only looking at our core function, but what are all of those other supporting players that allow that core function to operate? So if we go back, taking a look at a intensive care unit setting, it's much more than a ward or a part of one of our units in our hospital where we're going to throw some docs and nurses together and they say, great job, let's go save some lives. But there's a lot of other supporting players. We need the appropriate IT and IS applications, the appropriate equipment, monitors, support from pharmacy. We need our colleagues in respiratory therapy. We need our colleagues in other admitting and registration and PT and OT. It really is a pretty substantial response to kind of duplicate and expand these services. So we need to have a thorough understanding of who all of those players are. And the support of those key functions is something that we should readily incorporate within our business continuity plans. So when we say we need to relocate and or expand the intensive care unit, we have a distinct path that we can reference to see what do we look at from a staffing and staffing support perspective, from those equipment, from the applications, and also taking a look at the place itself. So we start to see that these core functions are dependent on many other department and supporting players. And when we talk about here in a little bit on how we help to develop our plans to support these different tiers of activation, especially as we look to reconstitute some of these services, we then start to develop a roadmap to response and recovery. The last component that we look at, as I just mentioned, is also looking at the physical place, right? So outside of where we have our normal operations, whether they be support operations, financial, administrative, or clinical, where are some of those different strategies? Again, if we lost an area due to a tropical storm, we'd have a significant utility failure. We have some structural damage that occurred from hurricane or tornadic event. Where are we going to go with that so we don't lose that function? Identifying locations within our organization, within our system, or within our region that we can go and reconstitute and stand up those key services and functions. And also in the event we may need to replicate or expand, we have a roadmap to follow as we were discussing as well. Because, you know, in our business, downtime costs more than just money, right? We all have in the healthcare community a very important role that we serve within our organization, our community, to help those who can't help themselves. And we want to make sure that we have the ability to meet those demands. And part of that very important consideration is actually going to be the financial aspect of it as well. We find that staff tend to like to get paid. They are reliant on that as well. So we need to have the ability to continue to do so, but also to ensure the financial health of our organization so we can continue to meet those needs that we have of our response activities. So one things I always like to implore amongst emergency management and business continuity professionals within healthcare is to really help insulate those key revenue generators as well. We've all seen from one extent or another as organizations have decreased or suspended some of those non-essential services. Some of those services deemed non-essential are also turning out to be significant revenue drivers of the organization, which then has a cascading impact, and not a positive one, on the rest of the organization. So while we know we're not in healthcare for the money, we do have a responsibility to ensure that we can work on and insulate some of those key revenue streams to support our primary mission of caring for the community. Another common question that we have that we always find is worthy to discuss is, how does our business continuity plan fit in with the emergency operation plan and then our IT disaster recovery plan? We don't want people to think that each of these are done in a silo. We're going to see here shortly that there's a lot of crossover between the two plans. And as we start to take a look at your emergency operation plan, your business continuity plan, and your disaster recovery plan, we need to start thinking of these as toolbox resources. We have a set of resources in each of these toolbox, whether it's ICS structures, our crisis communications, severe weather events, and our EOP toolbox. As we start to take a look at essential services, critical staff or equipment, and equipment that are needed. Locations, delegations, authority, those are tools in the business continuity plan toolbox. We also take a look at our disaster recovery plan from our IT and IS colleagues, talking about telecom, our network, our electronic medical record systems, all of those processes and applications that our community is so reliant on. And we need to understand that in development of these plans and also in activation during response and recovery efforts, they cannot be operated in within a silo. And we clearly see in different components and different times within our response, we can have overlap. So commonly, if you have a onset of a significant event outside of the pandemic where we did not have a lot of forewarning, looking at potentially a hurricane event or a tornadic event, we may be activating our emergency operation plan first to gather our hospital incident management team together. But due to the substantial impact or the identified prolonged response and impact of this event, we may shortly thereafter be instituting our business continuity plan to gather some of those resources to help us in our response and recovery efforts. Very likely, if we have a prolonged ITIS downtime, an unexpected downtime that is having an impact on some of that meaningful use data, on that patient information that we need to have entered in from our nursing flow sheets within our electronic medical record systems. Initially, that will be our DR plan that we go to, but again, shortly thereafter, we may be pulling out tools from that business continuity plan to address those long-term implications. What are those downtime strategies? Which downtime forms are we going to be reliant on? Who is going to be responsible for rekeying this data at various time thresholds within this response? So again, in development and execution, we need to understand that these are not developed in silos and they're not executed in silos. We need to understand how it is that we work together and start to familiarize our incident management teams with the different resources and tools in each of these toolboxes to help address and fix the problems that we have. Another common area of opportunity is, where do we get all of this information to write a comprehensive business continuity plan? And what we say in these instances is, it cannot be written by a single business continuity emergency management professional within the organization. It can't be turned over to someone in quality or risk and say, hey, we need you to put this together, go and run with it. We really need to rely on the subject matter experts within our organization and what they do. We need to get to the department managers, the directors, the frontline staff that are intimately knowledgeable about our day-to-day operations in those key functions. And not saying we need to interview every single person within our organization, but we need to gather key operational information that they are very familiar with. And anyone coming from the outside to try to replicate or duplicate it, we're going to have a lot of struggles and take on a lot of time. So this really is an all hands on deck planning effort where we want to tap the resources from all of those subject matter experts within our organization to truly develop a multidisciplinary plan. Because all too often when we see people from risk or finance or quality or just clinical that are developing these plans, we find out that you will soon tend to see, when they're developed in a silo, how it's heavily focusing on the financial part of it. Or if it's someone with a lot of clinical experience, this very quickly starts to focus on really the clinical operations of the organization. And we start to miss some of those key components like Kyle was talking about in terms of engineering that critical infrastructure within our organization, and even making sure that the business continuity and IT work with one another. So again, succinct interviews, key subject matters of those different departments and functions within your organization is that truly that best practice to help us gather a good and effective plan. So as we start to take a look at some of these key areas that we previously spoke about, I touched on the information technology piece. We talked about the downtime forms and procedures. Now, any of us have operated in healthcare, we know these exist, but one of the key things that we want to make sure we keep in mind is that as our electronic medical records change, right, as our nursing flow sheets, our physician H&Ps change, as we make changes to our EMR system, are those changes also reflected in our downtime forms and procedures? So just as we constantly evaluate and figure out how we can better streamline, make sure we make good use of that meaningful data that is coming into our EMR, we also need to make sure that on the back end, especially for those prolonged downtime incidents, that our forms and our processes truly are capturing the information that we need to have go back into it and to sustain that effective environment of care for our patients. One of the other items that we constantly see is when and who is going to re-enter that information back into our EMRs. We commonly see when we run these events and exercises that clinical staff will try to wait literally until the last minutes, sometimes right before their end of shift, to try to go and either document this on downtime forms or cross our fingers and hope our EMRs come back up. And we then tend to see that the information that is going in can tend to kind of degrade a little bit simply because of time or our inability to properly document it. So we need to have key triggers and thresholds of when we institute our downtime forms, at what point are we going to have staff or medical records or someone else be responsible for re-entering that captured information into the EMR, so we can give our staff a concise and effective timeline of what is going to happen at different milestones during the event. Because there's a lot of important information that we take a look at in terms of custody of data and also key information and metrics that may be reporting on for organizations like CMS if we come to our sepsis bundle, or if we have patients with MIs that we're trying to capture certain events, door to balloon time and things of that nature. We need to make sure that through our downtime processes, we have the ability to have all of these different items that are going to be captured. We also always recommend that on the front end and the back end of developing your business continuity plan, you sit down with those stakeholders from your IT disaster recovery plan and make sure that both of our plans make sense. So if IT is saying that our return time objective, affectionately known as an RTO, is going to be 8 hours to bring up our electronic medical record, well, we need to understand that if our business continuity plan says, well, we need this back up within the first 2 hours, there's going to be a gap. There's going to be a discrepancy. So we have to work together to either identify, is there anything that we can do on the DRP side to bring that return time objective closer to 2 hours? And if not, then it's reliance on us developing the business continuity plan to institute some of those downtime forms and strategies to get us to that point of their own RTO. So far too often, again, we see these siloed. We got to break down those silos, hold hands, play in the sandbox together to make sure this key information is being transferred. The other piece that we take a look at, I'm not going to reiterate this, Kyle did a real phenomenal job talking about the critical physical infrastructures and utilities within the organization. We consider this what we call tier 0 or your baseline, meaning if you don't have lights, HVAC, plumbing, or medical gases and air and oxygen, not a lot else that we can do. So having those redundancies and preventing those single points of failure that Kyle so eloquently discussed are really key components to what we're going to be doing. As I mentioned before, something that I personally hold near and dear is that I tend to work better and operate better when I'm going to have a guaranteed form of payment to put clothes on my children's back and to put food on the table. So having the ability to ensure our key financial functions are addressed within the organization are also going to be very important. So payroll and processing, not only our internal, but also taking a look at our banking partners. Are they a regional bank with a minimal set of resources available if there's an interruption or if they closed? Are they a national bank that has some additional resources to assist with having direct deposits made or having those checks that are going to be cashed? We need to make sure that we have some redundancy in that process so we can not only process the payroll, but the physical payments can either be direct deposited or the checks can actually be written to our staff as well. And then on the back end of things, they mentioned before, revenue and finance is never our key mission in healthcare is to save the lives of others and help those in their time of greatest need, but it truly helps make sure that the wheels of operations continue to pull forward. So having the ability to have processes in place for coding and billing, that revenue capture piece, ensuring accounts payable can still operate for us to pay our vendors, our critical contractors that we need, and our equipment suppliers in these type of events, and also to have processes for procurement to understand what those downtime procedures are, who has the delegation of authority for these different procedures, and then start to build some depth into our financial bench when it comes to these events. So if we do have a large loss from one department, we have the ability for others to pick up those reins and carry on forward with the mission of the overall departments. As I said before, human resources is a huge consideration, right? We all know that our staff, especially our frontline staff, are the most critical and crucial resource that we have in this response and recovery efforts. So one of the key things we talk about in terms of alternate staff options is we may need to get to the point where we're creative on how we staff these different areas, or how do we sustain staffing for these prolonged surge events. So as I said before, what is our process to repatriate some of these nurses that maybe have left our emergency departments, our critical care areas, or our intensive care areas? If they're still within the organizations in different departments, maybe they went to ambulatory surgery, maybe they're now in a clinic setting, what is our process to reconstitute them? And not just calling them and like my wife and say, hey, we need you back in the ER, in the ICU tomorrow. Well, there's more to that. What does it mean from an HR perspective? Is there anything else that they are missing in terms of credentials or certifications they may need? What does it look like to go back and care for those patients in the ICU setting? Again, my wife is a good example. She left the ICU about 5 years ago now, and her greatest fear wasn't taking care of the patients, but was to figure out, how am I going to document all this stuff back in a very different EMR than what I was previously used to. So having the ability to train and orientate these staff as we look to repatriate should be part of a larger plan. We can also see organizations that start to have effective plans to backfill some of these staffing resources into those areas, meaning taking some nurses from an outpatient clinic to med-surg, moving med-surg nurses to help support some telemetry operations, having telemetry start to support some critical care, and then having some critical care to support ICU, because we know that nursing and physicians, they're not all built the same in terms of their expertise and their repertoire. So we need to make sure that when we put staff into those different levels of care, they're set up for success, whether it's an intensivist that may be overseeing a couple other hospitalists or family practice docs that are now assisting with some of these expanded care areas. We need to make sure that they have the proper oversight, resources to go to ask questions for, and also training to be effective in the areas that we're putting them through. The last, but certainly not the least important piece that we take a look at is also going to be the supply chain considerations. And as Laura mentioned, outside of just the pandemic, but as we start to look at hurricane preparedness being in the season currently, we need to start to evaluate our suppliers and our critical suppliers to support our operations. And this may take a little bit of legwork on our part, working with those key vendors and suppliers to find out, what is your own plan? Are you have a regional distribution hub? Is there a national distribution hub that can assist us? And even starting to take a look at some of those key vendors and suppliers and saying, well, hey, where are your goods coming from? So if we have another hurricane that is targeting Puerto Rico or another part of our country, or the world for that matter, we can have the better understanding of how that impacts us. This is commonly something we don't see built out thoroughly within a business continuity plan, but it's a key responsibility to work with our supply chain partners within our own organization to start to identify not only what do some of those service line agreements, SLAs are for services, but also taking a look at where are we getting our stuff from? Do we even have the ability to have different vendors or suppliers? Or if we don't, what are those conservation strategies we need to develop within our own organization to make sure that we can not only calculate those resources effectively, but we also have the ability to start to institute some other procedures when we're looking to not have the appropriate resources available. The last two slides that we're going to be touching on here in my last minute or two is going to be prioritizing the functions of the organization. So once we identify all those key critical functions, whether it's support services, clinical operations, or those organizations that have research, another very key component that we talk about in the overall business continuity process, when we have a significant downtime, when we're aligning our resources to those key critical functions, what is it and when do we start to bring back some of these services? Who is it heavily reliant on? So this is kind of our roadmap to recovery and response, identifying who is it that we need. So bringing back that ICU example in a quick minute here, when we take a look at some of those support services like lab, respiratory therapy, pharmacy, all those key functions, they may be brought up first in that tier 1, less than 24 hours. So to ensure when we open up our clinical care areas, we have the appropriate resources that we need. Research may not be brought up immediately as a tier 1 responsibility, but some of our research may be very time sensitive, and we need to build strategies around what resources are needed to reconstitute those processes as well. But what we do understand is that everything is not treated equal in response. Disasters are because we don't have all the resources to effectively respond, but our business continuity plan should have the ability to give us a roadmap of when and how we reconstitute those services. The last piece I'm going to leave you with is sustainment, right? Making sure we educate key staff and leadership to the different tools in their toolbox that I was previously discussing. Make sure we regularly conduct exercise and implement the items from our improvement plan. Just don't go through the motions. Develop your after action report improvement plan and leave it as is. We got to act on it to make sure that we are being responsible and fixing those opportunities that we identified. And then lastly, as our services and our organization changes, we need to make sure that we adapt the plan to meet the current phase of our organization. So this isn't something that we do once and then we shelve it for the next 5 or 10 years. This has to be a living and breathing document within the organization. So with that being said, appreciate the time today. Greatly appreciate the opportunity to speak with all of you, long-term InfraGard member. And again, thanks for listening to my little discussion about business continuity planning in healthcare. And with that, I will turn it back over.
Thank you both for providing such a wealth of information. We do have a handful of questions that have come in, so we'll address as many as we can in the time that we have left. The first one I think could go to either one of the two of you, and it's about timing. How long does it take to develop a comprehensive COOP plan? And associated with that, have either of you heard of computer-assisted decision support tools that you might use to test or refine your COOP plan? Either one of you want to take a stab at those two?
Yeah, I can hop in on the front end, and I'm sure Cal has some more insight to provide as well. You know, there's different levels of maturity within a business continuity or a continuity of operations plan, meaning you're not going to spend, 12 to 18 months to develop a plan and have everything you need. Commonly, we take a look at this from a standpoint of you need to crawl before you walk, before you run. Step 1 in the process may be for us to simply identify essential services and essential staff, right? Step 2 may be for us to then start to build off and identify some of those interdependencies. Step 3 may be looking to put those different pieces into those different tiers of reconstitution for that roadmap to recovery and response. So you're going to have different levels of maturity, but the key component is if we start to develop those key tools, even some of the basic ones we can start to operationalize early on. But again, commonly what we see is a fully matured business continuity plan can generally take anywhere from about 3 to 5 years, simply because you need time to have exercises and real world events and learn through our ARIPs on what may need to be changed.
I think that was great. The only thing I would add to that is all of the plans that I showed you, that to me they're living documents. You never stop, improving, exercising, and revising the plans as you need. So I say, how long does it take? I say forever.
Forever. Wow, you guys set the bar high, but in an understandable sort of way. There's been several questions that have come in that are specific to the people part of the plan, and a couple of them are particularly relevant in the COVID-19 era. One of them is, how do you recommend that hospitals identify those folks who need N95s versus surgical masks? Because not everybody needs an N95. How do you put that in as part of your resiliency plan? How do you think about supply chain issues with that? Any thoughts about that?
Yeah, that's really a great question, and there is no easy answer. But what we do find works well is having a multidisciplinary team approach and kind of calculating your risks based on the mission that the staff are expected to fulfill. So whether they may be security at the front door doing temperature screenings for patients, visitors, or staff that may be coming in, where we have some of our support staff from our rock stars in environmental services or food and nutrition, or some of our clinical staff, we need to sit down with risk, with ethics, with our clinical leaders in the organization and take a look to see, what is it that they're doing in operations, right? What is a realistic and tolerable risk that we can take with providing them certain levels of PPE to prioritize some of those procedures and care that may be clearly aerosolizing droplets or may have very close contact. And also, what can we do with engineering to kind of create some environmental controls to mitigate that risk? So unfortunately, there is no one easy answer, but what we find that works best is getting together that multidisciplinary group and kind of looking through those different categories and having an open and honest discussion about what not only the risk tolerance is, but what is the operations folks focus on.
Got it. That makes a lot of sense. And to continue with that focus on people, a couple of different attendees have asked specific to people, when you're looking at what are the services and the people that you need in part of your supply chain, some of those people might be sick, right? The people that are providing those services. How do we make sure the necessary people are actually available? And someone else asked a similar sort of question: how do you incorporate backup considerations for superannuated, I'm probably killing that word, and health comorbidities among identified key personnel that are part of the plan's continuity parts? Any thoughts about that one?
No, that's another good consideration, right? And part of that is taking a look at our workforce and even that telecommuting capability, right? And focusing on, is this a function that we need to have within our organization? Can we minimize those who are in our facility, within our walls, that have key operational considerations that have to physically lay hands, scan items, or things of that nature, and then identifying those people who may have different comorbidities. I've been diabetic for 35 years, right? Thinking of working back in the ER these days caused me some concern, and I'm sure that there are a number of our colleagues across the country that are the same way. So identifying how we can leverage those key personnel and processes, again, definitely why even those key functions in supply chain, making sure they're not siloed around one or two people. We have downtime procedures to identify if I'm not available, who can take my place, and to make sure that procurement is not interrupted during this part of the event. But it also has to take, again, talking with your managers and leaderships in your department and identifying if we do have colleagues with potential comorbidities, what can we do to help ensure their best outcome from this event as well, whether it's prolonged teleworking, whether it's working in a different area that's well isolated from folks within our organization, but there has to be some fluid considerations.
Makes total sense. And I think given the interest of time and because you both provided contact information for yourselves, we're going to allow those who have questions that remain unanswered to reach out to you directly to get some information that they would need. Any final thoughts? Kyle, I'm going to turn to you first. Any final thoughts from you to leave with our audience today?
No final thoughts. I just appreciate everybody coming out and listening, and thank you very much for having me.
And Chris, any last thoughts from you?
Now, the last thing I'll just say is make sure everyone take care of yourself, take care of your colleagues. Know this is hard for everyone for different reasons. Make sure you tell your colleagues that it is okay to speak to them, and always go and understand where your employee assistance program is and also critical incident stress management resources in your community.
Awesome. Thank you both. And Laura, I'll turn to you for final comments.
Thanks so much for a great webinar today, both Kyle and Chris. Really important information and timely. A reminder to everyone, we'll take a break next Friday and we'll join you again on July 24th with a webinar on access controls. Thanks.
And one final reminder from me too is when you leave the webinar, you'll see our usual link to the survey. Please do let us know how today went, what we could do better, and in particular, if there are topics that would help you going forward to do your job safely and more efficiently as well. Thanks everyone for making time and space for today. Really appreciate your joining us. Please stay safe, please stay healthy, keep washing your hands, and we'll look forward to the next time we're all together online. Take good care, everyone.